What is normal labor? Uh, it is a physiological process and it will start with the remodeling of the cervix and it will end with the expulsion of the product, in this case, the fetus or the baby. Um, Gestational age can end at the end of the pregnancy as a full term can occur between 37 up to 42 weeks. It should be spontaneous in onset and in progression. And today we're going to start learning about the three stages of labor in order to recognize what is normal and what is abnormal. We have three stages. The first one will start with the regular uterine contractions and it will end in fully dilatation of the cervix. The second stage will be the delivery of the fetus, and the third one, the delivery of the placenta. The three P's are going to be the power done by the uterine contractions, the fetus is the passenger, and the third P is the pelvis, is the passage. So contractions should be regular and powerful enough in order to permit the fetus to the passage and in the outside of the pelvis. Let's talk about first and second labor stages from the first contraction to the delivery of the fetus. The cervical dilatation will be done in two phases, the latent phase and the active. Latent will be from 4 to 6 centimeters and active from 6 to 10. And here you can see an undilated cervix and how it shows the fully dilated cervix. It's up to 10 centimeters. This phases, active and latent phases, have different durations depending if the patient is the first time that is in labor or if it's a multiparous. So as you see, there's difference between 20 hours versus 14, and the active phase is more rapidly in multiparous. Take that into account when you have a patient as have you been in labor before? The cervical enfascement and dilatation. So enfascement has to do with the length of the cervix and dilatation with the opening. Here you can see non-enfased, not dilated, fully enfased. You see it's shorter and 1 centimeter open and fully enfased and up to 10 centimeters fully dilated. So how this works, the way the fiber cervical smooth cells are arranged in an architectural way that will permit the shortness and the dilatation of the cervix. We have longitudinal and also circular fibers of the muscles, and it will act like a sphincter. The cervical remodeling will be the collective term for the progressive cervical change and after recovering during pregnancy and involves 4 overlapping phases: a long progressive softening phase, an accelerated phase of marked softening and increasing of compliance near to the end of the pregnancy, that's called ripening, active dilatation just prior to the delivery, and then postpartum repair. Let's talk a little bit about the fetal membranes, the anatomy. We have the amnion that we see here. This is the amnion in color blue. Amnion layer will be the innermost layer that will contain the amniotic liquid or fluid, and the chorion. The chorion will be separating the amnions from the decidua. That's the innermost uterine layer from the maternal part. We also have the decidua capsularis and decidia parietalis. Both deciduas will come together when the baby starts growing up. It will come and form only one layer. And the same thing will occur to the amnios and the chorion. It will form the chorion amnios cavity, and it will be instead of two layers, it will become one. We also have the amniotic fluid. This liquid should be in the normal amount in order to permit the skeletal development and also the lung developments. Passenger or fetus. So during the second stage of labor, it will begin with the complete dilatation of the cervix, and it will end with the delivery of the infant. The second stage will have a duration of 3 hours with anesthetic, or 2 hours. In a premiparous patient, it will be reduced for a multiparous patient. The fetus has to do a lot of things in order to get through the passage, the uterus, and those different movements have different names. So the vertex of the fetus, we're going to talk about this in a few minutes, usually enters the pelvis in occipital transverse position, or called also biparietal position. And then it will descend to an occipital anterior position, occipital anterior position. The occipital will be facing the pelvis, and this will occur in 90% of the cases. So the first step, the head will go into the pelvic inlet. Then it will downward the passage, it will start descending. And here we can do in a palpation, determine what is the position of the fetus. Then it will do a flexion that will allow the narrowest diameter of the head, which is the occipital anterior. I will show it in a few minutes. And then followed by an internal rotation. That will be the fetal is now looking down. And the occipital part of the fetus will be in proximity to the pubis. The fetal head then will do an extension to go under the pubis, and then an external rotation. So it will permit to deliver one shoulder and then the other one, and the rest of the body with the expulsion. I will recommend you to see this video of normal labor. And here are the cardinal movements of labor in each one of the movements that the fetus has to do in order to be expulsed. It is important to know also the anatomy and the measures of an anterior fontanelle and posterior fontanelle. Posterior fontanelle will be close to the occipital bone, and it is the occipital bone, the one that's going to tell us the position of the fetus in the uterus. The anterior fontanelle is close to the frontal bones. So the presentation will be what is the presenting part of the fetus in the cervix. So the fetus can present the brow, is this one. It's the forehead. It has a larger diameter and it's incompatible, cannot be delivered by vaginal delivery. The vertex, it will be located between the anterior fontanelle, bregma, and the posterior fontanelle. That's the vertex presentation. That is compatible with 90% of normal labors. The face presentation will have anterior, mentum anterior, and mentum posterior. The mentum anterior presentation, that will be similar, the mentum close to the pubis, that will be compatible with the vaginal delivery. But the posterior, the mentum posterior, is not. So remember, MA can, PA can't, not for vaginal deliveries. Also, lie, the longitudinal lie and transverse lie. So this fetus will be in longitudinal lie when it's parallel to the maternal spine. When it's transverse to the maternal spine, it will be a transverse lie. Cephalic presentation. We have vertex presentation, military presentation, brow presentation, and face presentation, encephalic presentation. Also, we talked about positions. Positions means the direction of the fetal head in relation to the maternal pelvis in vertex presentation. So, talking about vertex presentation, okay, a vertex presentation, letter A, we are going to define a position. How do we do that? So, we're going to classify it as occiput anterior, occipital anterior, when the fetus is facing the maternal spine. And this is the easiest delivery. Occiput posterior, when the fetus is facing the maternal bladder. Occipital transverse, when the fetal head is sideways facing, it's not here, the maternal hip. So occiput transverse is usually the way the fetus enters the pelvic inlet, but this position will not let the head fit under the pubic bone. So a position will be, and this is the way, this is my left, this is my right hand. I am facing the patient. This is the bregma fontanelle. This is the occipital facing back, close to the spine. This is a left occiput posterior. And also, this is a left occiput transverse, facing the left, my left side. And this is a left anterior occiput, left occiput anterior. The same way, this is the occipitus, right occiput posterior. Right occipital transverse and right occiput anterior. This is for vertex presentation. So, We enter an occipital transverse position, then an occipital anterior position with a well-flexed head that will allow the suboccipital bregmatic or occipital anterior or suboccipital bregmatic diameter of the head, and also here the lateral biparietal diameter of the head of the fetus. Both of them, they measure 9.5. So when the head needs to go into the inlet, it will have to enter in the occipital transverse position, and if it goes to the outlet of the pelvic, it has to measure also 9.5 with the suboccipital bregmatic diameter. So we have the pelvic inlet and the pelvic outlet, right? So the pelvic inlet, we have a diameter, that's the smallest one, is 9.5. And that's why the head needs to enter in occipital transverse. And when we go to the outlet, the spines of the ischion will be the ones defining 9.5 diameter. That will be the suboccipital bregma diameter of the head. Also, the passage, the pelvis, it will have different shapes. We have a gynecoid pelvis. This is the best one. It will allow an occipital anterior position. The anthropoid pelvis will allow an occipital posterior position. Both of them will permit vaginal delivery. It will be difficult to engage the android pelvis, and it will be also difficult delivery when we have a platyploid pelvis. The position will be occipital transverse. And when it's an occipital transverse position, it won't be able to do a vaginal delivery. And also the android will be very difficult to have an engagement and of course to have a vaginal delivery also. The third stage of labor, it starts immediately after the delivery of the baby and it ends when it's complete the expulsion of the placenta. The normal parameters are less than 30 minutes. Typically, it takes up to 10 minutes. Here is the normal postpartum, if you want to read a little bit more about this reference. And the following slides are the general physiological changes. After delivery, everything should go back